Care Commission. Thank you for joining our learning event. Today, we will be exploring the connection between auditory health and overall well-being. The crowd today was intended to be smaller to promote an interactive conversation. To join the conversation, you may raise your hand or enter your thoughts or questions into the chat. Next slide, please. So I'm going to start off by telling you a little bit about the Maryland Healthcare Commission. MHCC is an independent state regulatory agency that supports advanced care delivery and practice transformation. Our aim is to shift the focus from quantity of care delivered to improved health outcomes and coordinated care delivery. This includes supporting innovations that focus on improving health equity, outcomes, and quality of care. We also educate providers and consumers on value and best practices. Next slide, please. So today's learning objectives include understand auditory health and its connection to your overall health and wellness, discuss how hearing loss impacts health outcomes and care utilization, discuss tips for recognizing the signs of hearing loss, and explore strategies for establishing referral and for relationships with audiologists. Next slide, please. So today we'll start off with an overview of the Maryland landscape. I'll do a brief overview of some current MHCC practice transformation initiatives, and then I'll turn to the main focus of our event today, auditory health and overall well-being. Next slide, please. So what does the Maryland healthcare landscape look like? We have 6.17 million people. 16.3% of the population is age 65 and over. We have the highest median household income by state, and we have 45 acute care hospitals, 2 of which are academic centers. Next slide, please. So Maryland has a unique healthcare payment system. The approach we use in the state enables cost containment for the public, incentivizes better health outcomes through pay-for-performance programs, avoids cost shifting across payers, and provides equitable rates to self-pay customers, funds investments in population health, and establishes Maryland as a leader in linking quality and payment. Next slide, please. So what are the components of the Maryland model? We have a hospital population-based revenue that expands hospital quality requirements, incentives, and responsibility to control total costs through limited revenue at risk. We have care redesign, new model programs, and the Maryland Primary Care Program, or MDPCP. These programs expand incentives for hospitals to work with providers. They also provide an opportunity for development of new model programs for non-hospital providers. The MDPCP enhances chronic care and health management for Medicare enrollees. Population health encourages programs and provides financial credit for improvement in statewide priority areas, including diabetes and opioid addiction. Next slide, please. I'll now provide a brief overview of practice transformation initiatives designed to support the Maryland model goals by readying practices to participate in value-based care models. Next slide, please. So the MHCC convened a health equity roundtable in March of 2022 with representatives from advanced care delivery to identify challenges and opportunities for practices seeking to address key health equity concerns in their communities. The goal was to advance health equity in ambulatory practices through the development of practice resources informed by the roundtable. So the roundtable informed a health equity symposium of March of 2023, which focused on strategies for identifying patterns of need in the community, building referral networks for services related to social needs, and connecting patients to resources. More information about the roundtable is available on our website at the link on this slide. Next slide, please. So how is MHCC supporting practice transformation? So we released an announcement for grant application in May of 2021 to identify a care transformation organization to engage small primary care and specialty practices in a practice transformation program. The grant objectives include preparing practices to deliver efficient, high-quality care while improving health outcomes and setting the foundation for practices to provide team-based patient-centered care. Next slide, please. So in June of 2021, MedChi CTO was competitively awarded a grant to complete practice transformation activities. A crucial role of the CTO is providing practice coaching on specific transformation topics and approaches, such as quality improvement and tools to help sequence and manage change essential to succeed in a VBC model. The program milestones include a readiness assessment, workflow redesigns, and training. Next slide, please. So we have approximately 27 practices currently engaged in round one that are projected to complete the program this month. An additional 15 practices begin in round two in January of 2023, and they're projected to complete the program by June of 2024. Next slide. So the MHCC convenes peer learning network events like this one in collaboration with local and national health leaders on topics such as health equity, advanced care delivery, and practice transformation. More information on our learning events is available on our website at the link listed on this slide. Next slide, please. So two recent learning events included the Health Equity Symposium I mentioned earlier and Assessing and Vetting Community Resources. Next slide, please. So I'll now turn the presentation over to Dr. Ratinsky to discuss our main topic for today's learning event, auditory health and overall well-being.
Excellent. Well, good afternoon, everyone, and thank you, Melanie, for that kind introduction. My name is Dr. Abigail Ratinsky. I am a clinical audiologist and have been practicing in the field for around 5 years now. I currently own and operate a practice located in Severna Park, Maryland. I offer a variety of audiology services, including general hearing testing, hearing aid fitting and servicing, balance testing, tinnitus management and assessment, along with a variety of other services, most of which I am also able to offer to patients who are in home and assisted living facilities as well. I do also specialize in balance testing and disorders. As an audiologist, I work very closely with various providers and specialists within the medical community. And now I'd like to introduce Catherine Grote. She is family nurse practitioner in the area.
Thank you, Dr. Ratinsky. It's my pleasure to be part of this webinar series. Thank you, Melanie. As Abigail, Dr. Ratinsky, I apologize. As just stated, I'm a family nurse practitioner. I've been in practice for about 13 years, but a nursing assistant adding in there, it's about 16 years. So as we know, auditory health is something that we've all encountered in our loved ones, our friends, our community members, and hopefully this presentation helps you see how health outcomes and hearing loss can possibly be reversible or avoidable for the future. So Dr. Ratinsky is going to now explain about the hearing process. Next slide, please.
So this diagram here helps us to understand just our basic auditory process as far as hearing goes. Our auditory system is composed of our outer ear, our middle ear system, and our inner ear. The inner ear contains our hearing organ, which is known as the cochlea, and our balance organ, which is the vestibule. When sound first enters the ear, our outer ear or our pinna, which is shown in the orange there, picks up that sound. Our auricle or pinna then sends the sound into our external auditory canal. And the next place that sound enters to is that middle ear system, which is shown in the pink on the screen. Our middle ear system is composed of our tympanic membrane or eardrum, along with the ossicles, which are our three smallest bones in the body. So once that sound wave has entered into the ear canal, our eardrum starts to vibrate. And it's that vibration along with our three bones that help carry the sound wave from our middle ear system into our hearing organ, which once again is known as our cochlea. Our inner ear is full of vasculature that helps supply nutrients through the bloodstream so that our ears are able to function. Our cochlea is the end hearing organ, which is innervated with nerves that help transmit the incoming auditory signal to the brain. The auditory nerves are what allow us to not only hear, but to comprehend and understand speech. Next, we're going to explore how healthcare diseases and comorbidities affect our hearing and how untreated hearing loss and balance disorders can affect overall quality of life.
Next slide, please.
Oh, perfect. So hearing plays a vital role in our health and well-being. This picture is a great visual aid of how hearing problems can be related to a variety of other health concerns or disorders, some including safety and balance, ototoxicity. So with ototoxicity, we're thinking any medications that can have permanent or temporary effects on our hearing organ, in addition to tinnitus as well. What we do know about tinnitus is 1 in 15 adults will experience tinnitus throughout life. What varies, of course, based on the individual is the severity of the tinnitus and the level that it impacts their day-to-day life. We do know there is a strong connection between tinnitus, ringing in the ears, or untreated hearing loss. We don't know the exact cause, but we do know that by essentially retraining the brain to forget its own ringing or other sound that it's created through the use of sound, hearing aids, and also cognitive behavioral therapy, we can help our patients better manage their tinnitus symptoms.
So as Dr. Watinsky mentioned, those few things, as you see on the slide, there's a few kidney disease, osteoporosis, dementia, smoking. All of these usually relate to those diseases causing a microvascular change, so reducing the blood flow to the area of the ear, the brain, as well as causing those nerve issues, right? And those are what Dr. Watinsky had mentioned earlier about the functioning of the hearing process can be inhibited because of those other diseases or disorders. Next slide, please. About the comorbidities and complications from hearing loss, which can be profound. For example, the comorbidities, those with history of stroke, dementia, recurrent concussions, head trauma are at increased risk of neurological systems malfunctioning, I apologize, causing the hearing damage or hearing loss and damage to that part of the brain. Approximately, this was pretty fascinating, approximately 33% of people over the age of 60 have some form of hearing loss. 67%, you see it goes up twofold in those over 70 years of age, so just in 10 years. Then also we have to think about our younger population. 12 to 15% of school-age children have some degree of hearing loss. Because hearing loss impacts so many social interactions, family connections, workplace productivity, it can have a greater impact on life than cardiovascular disease, than osteoporosis, strokes, sciatica, cancers, and many other conditions. So this is something that's more profound, but we're not hearing about it as much until we've had this great opportunity compared to other comorbid conditions. People with hearing loss are also more likely to experience earlier onset dementia, earlier mortality, and falling or balance issues than those with normal hearing. So this is why it's so important to really be aware of these. Next, Dr. Watinsky is going to go over this really fascinating slide. Next slide, please.
Perfect. So what we have showing here is a study that came out of the Lancet Commission from 2020. Essentially what this study was looking at are the risk factors for dementia, and they broke it down throughout the different stages of life, of our life cycle. It was found that untreated hearing loss in midlife is the #1 modifiable risk factor for developing dementia and cognitive decline later in life. This connection exists because essentially our ears are a use it or lose it system. When there is an underlying untreated hearing loss, our cochlea and our auditory nerves are not receiving that same stimulation they once were. And the signal that the auditory nerve is supposed to be sending to the brain is no longer making it there. It's essentially gotten lazy. In turn, the brain is no longer receiving that auditory input. It dips into our cognitive piggy bank where we've been storing auditory input and information throughout life to piece together any context clues or pieces of information that we might be missing. With our brain relying on that cognitive piggy bank, If we continue to draw without putting in anything more, that's where we see that cognitive decline start to occur. Recent studies have shown that hearing aids are actually slowing down the progression of dementia and cognitive decline, because hearing aids are designed to stimulate the system. Essentially, they're going to get not only our ears, but those auditory nerves working again and reestablish that connection. Next slide, please.
So as we're building on this whole hearing loss information, we're seeing how it can impact health outcomes and care utilization. As we know, communication is the foundation of relationships, both auditory communication and nonverbal communication. With loss of hearing, one can feel a loss of relationships with family, friends. It can also cause a feeling of isolation from those they love or care about. For those with hearing loss, it can really take this emotional and mental strain, this big impact on them. It can increase the risk of depression, feeling isolated, and hearing fatigue. Imagine struggling to hear those around you all day. It can really wear you out. Think about this then, if you work on a computer, most of us can attest to this through the pandemic. You're working on the computer all day, staring at the screen, and your eyes get tired, you get a headache. So in the reverse, think about that being your ears and how you could possibly feel that hearing fatigue. Due to hearing fatigue, it compounds the risk of isolation and depression. These are all big red flags that we can all be aware of and those around us. As healthcare providers, it means greater observation and intuition into our patients' hearing abilities. Part of our practices, Dr. Ratinsky, is home visits and office visits, and home can help us see a little bit more insight into possible hearing issues. Next slide, please. So as we stated previously, it's important for providers to be aware of our patients' hearing abilities. If there's not clarity in the patient-provider discussion, no matter who the provider is, no matter who the patient is, it can lead to problems with the discussion, evaluation, the treatment plan. There can be problems with compliance due to hearing impairment alone. For example, I have heard of this scenario. A patient was told to apply a warm compress to their skin for an abscess for about 5 minutes, 3 times a day. Instead, she applied a heating pad to the area for over 30 minutes twice a day and ended up with some skin burns, and it caused a worsening infection, and she had to go to the hospital. So we're trying to reduce these sort of incidences. And that was because she just didn't grasp what was going on, even though it was also documented in writing. She missed that piece. This is one example of how hearing impairment can really cause some health risks and concerns. So that ties back into our safety piece. Due to health risks with hearing impairment, there is higher risk of hospitalization. There is an increased risk of cognitive decline and dementia, as well as safety concerns like falls and not being able to hear sirens, not being able to hear smoke alarms or detectors. Dr. Ratinsky was going to add a little more to the safety piece here.
Yes, and I think it is important to note that with our senior population, the latest statistics are showing that 1 in 4 older adults will experience a fall. Recent studies that are actually being conducted by Dr. Franklin at Johns Hopkins have shown that untreated hearing loss can increase an individual's risk of falling by trifold. And of course, we know from those falls, if we're dealing with a broken hip or concussion or more serious injury, once again, we see that risk of hospitalization going up. Next slide, please. So these are just some tips or ways to be on the lookout for a loved one, patient, friend who might be someone that needs to go and see an audiologist just to get that good baseline test. If you're noticing during conversation that the person you're communicating with is asking for repetitions, saying what, essentially that's telling you they're hearing you, but they are having that difficulty with understanding. If you're noticing that the TV volume has gone up or the telephone, another good indicator of, okay, hey, it might be time to go get those ears looked at. Another common report is that everybody around me is mumbling or soft-spoken. Once again, that's an indicator that we could be seeing some high-pitched hearing loss creeping in, inappropriate responding to conversations. And then, of course, we also see other reported symptoms such as tinnitus, that ringing or roaring in the ears, that can be a sign of underlying hearing loss. Current statistics show that it typically takes an individual 7 years to come in for a first hearing evaluation from when they noticed a change in their hearing. If we're able to shorten that time frame, if there is intervention or treatment that's needed with amplification or hearing aids, it's better to do that sooner rather than later. And next slide, please. So here we just want to talk a little bit about some strategies for developing referral relationships with audiologists. From my personal experience, I have done a few lunch and learn events with local physicians. Some have been focused on diving into those comorbidities a little bit deeper. We've also focused on memory care, and then of course balance disorders as well, and essentially how I can help your patients have the best quality of life and make sure that if they are having those hearing troubles, we're not seeing them slip into depression or isolation. Some interdisciplinary fields that I work with frequently would of course include primary care providers, internal medicine, ear, nose, and throat doctors. I work a lot with physical therapists, speech language therapists, OT, ophthalmology with balance disorders. So really that interdisciplinary component is just so important to making sure that we're looking at that holistic approach for the patient. Another great way to start developing relationships with audiologists is by paying attention to local events, whether it's a senior health fair or local health fairs. I know I've done quite a few events in the past where I'll offer free hearing or balance screenings, and it's really helped open the door to establish a great referring connection. Next slide, please.
So I'm just going to chime in here in a hot second.
Oh, yep.
So Dr. Ratinsky and I were kind of discussing when do we get baseline hearing tests? You know, that's a big question. Piggybacking off of that referral aspect as providers of family practice, if I have a husband and wife coming for an appointment and the wife's like, oh, he doesn't hear me all the time, that should be a red flag. Let's get you a hearing test. But it's how, for me as a primary care, how can I soften that, so to speak, blow? Because nobody wants to hear, I need hearing aids. So it's putting it in a perspective that it can help reduce all of these risk factors for other chronic conditions. And who wouldn't want to reduce your risk of dementia later, or Alzheimer's, right? Or falls, things like that. So it's very important. And we were talking about the age groups.
Yeah.
U.S. Preventive Task Force.
So U.S. Preventive Task Force does recommend anybody at the age of 50 have a baseline hearing evaluation. Where I focus more on with the physicians I work closely with is really anybody of the age 65 and up. What we know about presbycusis or age-related hearing loss is we'll start to see that onset around 70. Of course, once again, the progression severity of that loss would vary on the individual and other underlying health conditions. But I think it is crucial, especially knowing this connection between cognitive decline and hearing, that everybody over the age of 65 at least has an annual hearing screening, if not a full evaluation. And just the extra good bit of information to know, Medicare does allow for one hearing test a year with a referral. So it is something that insurance would be able to cover for patients as well. From here, what we'd like to do is demonstrate a few different case studies where we would be working together collaboratively and essentially outline an ideal patient referral from both sides.
So these
Next slide, please.
these scenarios will help, hopefully, really anybody pull all the pieces of everything we've been talking about together. So the first scenario is a 32-year-old female patient comes in to see me, the primary care, due to some dizziness and lightheadedness. She says the dizziness is more with movement and actually makes her feel nauseous. Also occurs when she's laying down, right? Not just moving. No other symptoms, no recent illness, no recent travel. She does endorse a recent amusement park visit, and that should be a red flag to providers. She loves roller coasters, the twisting, the twining forwards, backwards, that jerking around of that head. Probably didn't drink a whole lot during that amusement park ride either. Nobody wants to be in the bathroom the whole time they're at the amusement park. We're going to go to next slide. So some of those key things that we looked at were we're getting the history and obtaining that from the patient, and it tells us a lot of red flags in there. In my office, I would have performed basically an ear exam. So looking, as Dr. Ratinsky said, the pinna, the ear lobe, looking at the ear canal, making sure nothing has traumatized that. The eardrum, did she rupture it and that's why she has some dizziness, or is there fluid behind the eardrum? Those are things as a primary care I can look at. I can do some balance things with her, basic things. I did a neuro exam, feeling for sensitivity, looking at the facial features, making sure they're on proper alignment. So doing that whole neuro exam. And the only thing, she had a little bit of nystagmus, which is the twitching in the eyes as we have the patient follow our finger across without moving the head. And she did get a little bit of dizziness with that exam. Laying down, she had some issues when she was laying down and turning her head side to side. And that would elicit some of that dizziness for her and a little bit of nausea, regardless if the lights were on or off. So the next thing that I would have done would be send her to Dr. Ratinsky or an audiologist for a full vestibular evaluation to rule out, is this BPPV or is it something else going on? And I'll let Dr. Ratinsky if there's anything to add on that scenario that she might do a little bit differently than just your traditional primary care.
So for this patient coming into the office, I also will do a comprehensive case history. We look at not only that dizziness portion, but are we noticing changes in balance, vision changes, anything that's essentially affecting ability to go throughout the day doing your normal activities. We also always conduct a hearing test when we do a comprehensive vestibular or balance evaluation. The simplest reason is in the brain, our hearing organ and our balance organ share real estate. So we want to look at both organs to make sure that if one was affected, the other was not. So in this example, I would set the patient up in the sound booth, go through a full hearing test, and then we get them set up for what's called a VNG. It's all about tracking eye movements. We say the eyes are the windows to the ears. But it gives us really good data. It gives us a lot of information, not only about the balance system, but is it the ear that's making us dizzy? Do we need to go for vestibular rehabilitative therapy? Or if the ears are in good, healthy condition, is this something where we should follow up with ENT, ophthalmology, neurology? So really, we use our balance testing as a tool to rule the ear in or out. In this scenario as well, if I did have to refer that patient on to another specialist, I always include in my reports that they should consult with their primary care physician as well, because ultimately we work as one team in the patient care management.
And I forgot to mention, of course, vital signs are a huge role in this, right? Do they have high blood pressure on top of this, or are they diabetic? Or do they have a history of smoking? So as Dr. Ratinsky said, getting that really good, thorough history is important at every appointment. Taking that time to actually listen and be able to use that in our problem-solving strategy. Next slide, please. So this is our scenario number 2. So we try to hit all different age groups, and this an 86-year-old male comes in to see me or any primary care, PCP is primary care provider, with his wife, who reports she has noticed her husband becoming more forgetful. He's also had an increased need for repetitions during conversation and has noticed he has stopped attending a lot of his social gatherings and has avoided noisy, crowded settings. Is this old age? Probably not. As we get older, we tend to be, if there's hearing loss, we seclude ourselves a little bit more. She also, the wife reports that he tends to shuffle his feet when moving around, and he uses an assistive device on different surfaces for walking, she reports like he'll hold on to the wall, for example, or if there's a railing, he'll do this instead of just putting one hand on that railing. She reports one significant fall most recently and expresses concerns what could be causing all of these things. So of course, we're going through, next slide, please. So of course, again, bringing it back to, it's really doing the investigation, and we get a lot of that from getting the history, and getting that history helps us to figure out what detailed focused exam do we need to do. Do we need to do a whole head to toe? Do we need to do it neuro? As Dr. Tinsky said, a lot of those specialists that she referred to, we have to put bits and pieces of that into our exam, and that helps us determine, as primary care anyway, of who they need to see. I know audiology would probably be similar depending what the history and the examination, putting all of that puzzle together on where best next steps for the patient. So we took a comprehensive detailed history exam, which revealed significant history of loud noise exposure. An otoscopy, or looking through the ears, was pretty normal. I'll let Dr. Ratinsky add on to this because
Sure.
it's more detailed in her realm.
And as Catherine was saying too, in audiology, I like to think of it as we're really just putting various pieces of the puzzle together. So we have that increased need for repetitions. We're starting to see forgetfulness and changes in balance. In order to really have a clear idea of what's going on, we have to take a step back and once again, look at all of those symptoms. So we'll do that outer ear examination, our otoscopy. We also perform a middle ear analysis. That's what would come up and show us if there was a history of an eardrum perforation, if there's fluid affecting his ability to hear. The second test that we perform is an inner ear analysis. So that's solely looking at our cochlea, our hearing organ. And in this patient's case, we did see weaker or total absent responses. With his age being at 86, I would expect to see weaker responses. Essentially, it indicates throughout life he has used his ears. And then the last part of that initial appointment was getting him all set up in the sound booth, where we saw severe sensory neural hearing loss in both ears. We know that he is a very strong candidate for hearing aids, not only from that testing, but from that reported case history. We don't want to see quality of life become impacted because he has begun to isolate himself. We want to make sure he is hearing his wife, or like we talked about earlier, smoke alarms, sirens. And then of course, we want to keep him sharp. We want to keep that connection between the ears and the brain moving as well. Next slide, please. The second part of this evaluation that we would have done as well is our balance testing, similar to what I had discussed a little bit with our last case study. Essentially, I went through a full balance evaluation with this patient, and it showed me a total vestibular weakness. What that means is balance system is way weaker than what once was. So it helps us to understand why that patient's not moving quite as confidently. We see that increased risk of falls. My recommendations, once I've compiled all of these different pieces, would include binaural amplification or hearing aids to stimulate the auditory pathways, reintroduce that connection. I would also recommend vestibular rehabilitative therapy with a focus on gaze and stabilization exercises. I do recommend annual hearing evaluations for anybody that we see hearing loss during that baseline evaluation. And once again, really key to refer back to primary care to make sure the whole team is on the same page. Next slide, please. And this is our last case study that we prepared. We wanted to include the pediatric population as well. So for this case study, we are seeing a 3-month-old infant and mom for a hearing follow-up. So they're actually starting in the audiology office. Mom reported that the newborn spent 6 days in the NICU and failed her hearing screening at the hospital twice in both ears. Following the stay in the NICU, no other medical concerns were reported. Prenatal care was received from 8 weeks. There were no additional reported complications during the prenatal period. And mom did not use any NSAIDs or acetaminophen, during that time period. Next slide, please.
And that kind of relates to the ototoxicity or concern of development of the ears.
Absolutely. So once again, we're always going to start that appointment with the thorough case history. It's really important too that for this, we're looking at a family history of hearing loss as well. We're also looking at developmental milestones. As far as the evaluation goes, with being an infant, I'm really only able to do a few select tests. Of course, we want to make sure there's no wax in the ears that might have resulted in that fail. I did conduct a middle ear analysis, which showed normal eardrum movement, no fluid behind the eardrums, and I was able to obtain beautiful and robust responses from our inner ear analysis, indicating that there's no damage to the hearing organs and hearing sensitivity would be within that range of normal. From here, I am going to refer back to the primary care physician to make sure that this is all documented and the state is made aware the infant has had and completed their hearing screening.
Just for those that may not know, if you've had children, you probably have seen this done in labor and delivery. What do you do for a newborn? How do you test their hearing? Because they can't talk to you.
Excellent question. So we use an objective test. We use distortion product otoacoustic emissions, DPOAEs. Essentially, it's an inner ear analysis. What we're doing is we are sending a very small signal into the hearing organ, the cochlea, and we're actually looking for the cochlea or hearing organ to send a signal back out. So this test can be done with the patient asleep. It does require that the patient be still, quiet, and not moving. So a lot of the time where we do see refers or fails from a newborn hearing screening in the hospital, movement from the patient along with patient noise are factors that absolutely have to be included, because if the newborn is fussy, crying, hungry, we're not going to be able to run a thorough, clean, accurate test.
Thank you, Dr. Atinsky.
Sure.
As far as the primary care standpoint, it would just be reminding parents, loved ones, keep an eye on developmental, any delays or anything going on from there. Always doing that good ear exam, provider checking for those developmental milestones and making sure they're on track. If they fall behind, referring back to audiology, as that could be a sign. They may not be hearing right, they may not be seeing right. Lots of different things that we can evaluate. And that's how the collaboration works. So we're going to go next slide, please. So how can primary care providers and audiologists collaborate for the common good of the patient, which is what we've emphasized a little bit throughout this presentation. And it's just so important. The ability to collaborate depends on, I can attest to us as providers, there's not a whole lot of time in the day, and we do this because we love doing what we do. But taking that extra time to reach out, call Dr. Ratinsky, call the audiologist, call the neurologist, whoever it might be, to discuss the case with them if there's time, not just sending the note over, not just a fax or something like that to review, not just sending over the specialist note or the primary care note and saying, in the patient note, advised to follow up with the audiologist. Well, sometimes there's a disconnect when, as providers, we're reading that and not sure chronology, time of events, where we're at in the treatment of that patient. And sometimes that's how things can get missed. So always reaching out by phone is always good. Some providers like to be texted, hey, when you have a minute, I have a case I'd like to discuss with you. But doing that really is most beneficial to our patient population. Nowadays, technology aids us in better communication if utilized. So yes, those through the medical records, the faxes, the phone calls or texts are all ways we can do that. But send that note, but also follow up with a call. Unless the provider, I have a couple of specialists that request me to text them and say, hey, heads up, I'm sending you a note. I'd like to touch base with you on this later when you have a moment. And it might not be that day, and that's okay, but we need to make sure we follow through for our patient benefit and health. Knowing the scope of all of our practices. And just like Dr. Ratinsky had mentioned, she did some lunches and some fairs and things, getting her name kind of out there, but also it helps the layperson and other providers understand what that specialty really does. So putting yourself out there is a great option of understanding and knowing that. And also you can provide better care and referral to our patient population if we fully grasp the understanding of the scope of practice for a different or given specialty or provider. And then also lastly, it's knowing when to refer out versus managing it internally is a big piece. I precept students, so that's my number one question from them. I don't know if you can attest to that too. When do we refer out? When do we try to do as much as we can without causing any detriment to the patient? So that can be a hairy situation, but that's a per basis client kind of situation. And always, it never hurts to reach out to collaborate just to get some additional input. And if I reached out to Dr. Ratinsky and she said, well, have you done XYZ? And I'm like, oh, well, I can do that if you would like me to, or would you like to just have the patient do it there in your office? And that's how collaboration works really well. Sometimes it's challenging, but it's really the best optimal option.
Absolutely, absolutely.
And anything else you have to add, Dr. Ratinsky?
Not too much. I think really the only piece I would add is once again, if you are looking to build those referrals, even having the lunch and learn with an audiologist or another specialist and really asking, okay, who would be that ideal referral? What's that key word I'm looking for where, okay, this is something that needs to be evaluated further. I know exactly where to send you. I found that even just connecting with physicians in the office has really been helpful on both ends. Aside from that, I think now we're open to taking some questions and about any of the topics we've discussed. We thank you all for attending and giving us your time.
Thank you, Dr.
Bachelor-
Ratinsky and Catherine. We appreciate the information that you've given us today and talking to us about how to work with specialty providers in the community. So I do have a couple of questions. So what are the differences between an over-the-counter hearing aid and prescription? Because, we know now that places like Best Buy are selling hearing aids. So what are the differences there?
That's a great question. Within the last year in audiology, things have really changed. Last fall, it was officially signed into executive law, the over-the-counter direct-to-consumer. And essentially what that allowed is for patients, individuals to now go directly to a CVS, a Best Buy, and actually purchase over-the-counter hearing devices versus going through the process of having that hearing test and being fitted with prescription hearing aids. What's tricky here is the information or access that I have to inside of the devices. But what I do know about the over-the-counters is they are designed for a mild to moderate degree of hearing loss. As far as cost goes, we're looking at closer to $700 to $1,200 for a set of hearing aids, whereas standard prescription hearing aid pricing has really ranged from $3,000 to $6,000 for a set over the last 10 years. I think the really big positive to the over-the-counters now being available, aside from the budget piece, is they are an excellent way to bridge the gap, maybe for somebody who's in that midlife where they're noticing some hearing difficulties, maybe it's in noise, but aren't necessarily ready for the full hearing aid amplification. It's a great stepping stone. What's unique about these devices is they are something that's totally self-programmed by the patient. So you would actually go purchase the devices. There's an app that you download where you complete a hearing test through the app. And from there, you do a lot of the programming. I've seen some challenges there, of course, when we're working with the senior population, and a lot of them turn their head and say, I don't want to mess with the technology. I don't want to deal with it. What I've done is just offer services for those who do decide to go the over-the-counter route as well. Aside from that, the other biggest difference is really the customization that we're able to do. Once again, over-the-counter devices are going to be programmed by the patient themselves and limited to what that that app software allows them to do. Whereas with the prescription hearing aid, we're able to get in and make this specific, customized to the patient. We're able to verify that they are receiving the gain and benefit that they need through real ear measurements and a few other tests as well. So once again, I do think they're an excellent option to bridge the gap. I think they're going to help break down the stigma of hearing aids being associated with old age. I know I have patients coming in and one of the first things they say is, well, I'm concerned of the look. I don't want the big bulky piece on the ear. And what's great is the over-the-counter devices are really just kind of normalizing that piece as well. I hope, does that answer your question or whoever's there too? Excellent.
Thank you. So when should patients be concerned about tinnitus?
So it's a great question. As I mentioned before, it is very common. And I think what's really important for patients to understand as well is the tinnitus, which once again can present as ringing, whooshing, buzzing. It doesn't indicate that something else is wrong necessarily. We can have that ringing in the ears with normal hearing, but maybe there's been a little bit of damage or wear and tear to our hearing organ. I think that's a really big piece. For me, if the ringing in the ears or buzzing is interfering with day-to-day life and your ability to make it through certain activities or tasks, if you're not sleeping at night because you can't escape that noise, if you find that you're avoiding quiet almost all of the time because when you're there, it's increasing anxiety, it's increasing stress, absolutely something that should not be waited on. Because with tinnitus, what's really tricky is it gets into a very vicious cycle with stress. And what I see happen is with patients who are experiencing this new ringing that's gotten louder, it's all they can think about, their stress levels have gone up. And now that ringing's gotten louder. So the sooner that we're able to address it, the better the outcome. Also, anytime we hear a sudden new sound, or if we're hearing our pulse in the ears, it's what we call pulsatile tinnitus. That is an excellent time to come in. I would say see a primary care physician, and then we want to do a full audiological evaluation and probably include ear, nose, and throat in that referral chain as well. And then anytime we see a sudden onset or start of that ringing or noise, and if we're dizzy along with it, or a sudden change in hearing. So anytime we have that sudden onset and it's accompanied with another symptom, another great indicator that it is something to be evaluated.
Yeah, so that kind of segues to the next question about when they should see someone about changes in hearing and balance. And also, I guess, who do they see? So do they start with Catherine, or do you recommend if they start with someone like yourself, if they notice balance issues or sudden hearing issues?
Probably ultimately depends on their insurance. I'm sure there's a lot of people, if they don't need a referral, they'll just go right to the specialist. But there are other times where people start at their primary and then go out. So you see a little bit of both, to be honest, at least I've seen.
Yes. So with Medicare, typically we'll see them go through primary care first, because I can't see them and bill for it without that referral. With balance changes and really what's tricky about the balance world is it encompasses so much. So if it's something where somebody's noticing more of a lightheaded or brain fog, a lot of the time they will start with primary care physician to go through the blood work, to go through, and I'd let you speak.
Possible imaging, something like that.
Exactly. You know, is there something that we can address medically, or is it maybe an increased dosage of medication that we need to look at? And then from there is when we'll see the referral out to my office.
And we talked a little bit. I'm sorry. Go ahead.
One other piece I was going to say is anytime someone wakes up and there is a sudden change in hearing where they are just noticing, wow, that right ear is picking up nothing. The sooner you get in, the better of a chance we have to actually restore that sudden drop in hearing. So that's one where honestly, wherever you can get in first is best.
Yes, I was actually just going to say the same thing. Sudden onset sensory neural hearing loss is a medical emergency.
Yep.
And they need to get evaluation treatment that day that hopefully that it occurs, so it can hopefully be reversed and it doesn't become something permanent.
So thank you for that information. And so for the last question that I see at this time. So you mentioned this a little bit earlier, but is there a particular age when you recommend people to start getting regular hearing tests or screenings?
I recommend 65.
And remember in our schools, we were talking about this a little bit earlier, they do hearing screenings, but it's not optimal. So parents, loved ones need to be aware. Again, is the child developing, getting through those milestones? They're on track with their reading and their writing. They can see the board. Is the teacher noticing that there's some attention problems? Even we think of ADHD, possibly, or anxiety, depression. Anytime we're around a pandemic, the next 5 years is a surge for mental health issues. And we have to make sure, is it that, or is it hearing, or a little bit of both? So noticing and picking up on those things in our younger population, right? That was the 10 to 15% of our adolescents have hearing problems.
Right.
If I remember that proper. Don't quote me on that percentage, but it's somewhere around there. And to me, that was a little bit astonishing to really read and to learn,
Yeah.
because we forget about the younger population. We're always so focused on that older, it's a sign of aging, a little bit of that hearing loss, not in everybody, but we're always so focused on the older that sometimes we might miss those kiddos too.
Absolutely, yeah. And so that's great with the pediatric populations. Of course, it is the benefit of doing some of those hearing screenings in school, pediatrician offices as well. Aside from, as we said, it is recommended that at 65, we at least have that baseline hearing test. If we see normal hearing, typically I'll recommend every 2 to 3 years for a retest unless I see a change. And then other considerations would be if you're an individual with a strong family history of hearing loss, that genetic hearing loss can certainly appear much sooner than 65. And that's something where, once again, sooner we catch it, the better. If you are a diabetic, and that's something where, once again, age isn't as big of a consideration as how long were you in the pre-diabetic stage for? Is it now being managed and monitored? That's someone who I would encourage to come in sooner as well. So in line with ototoxicity, if you're someone who was diagnosed with cancer, going through chemo, radiation, taking ototoxic medications, I would also recommend having a baseline hearing test and one to compare to, because radiation can absolutely affect our hearing and that auditory nerve. And so if we're able to just monitor it, we can help prevent further damage or loss.
And in the primary care setting, in addition, any of those comorbid conditions we talked about really should be red flags of recommending to the patient. I think we should just get a baseline hearing test. If it was your old ticker or your heart, you'd be like, yes, let's get that EKG, but we forget about the hearing and getting that baseline as well. So it's something I think should just be put right in there with our what do we call it? I'm drawing a brain fart, I apologize. Our health, the whole like
your annual health regimen, right?
Yeah.
We do every year, especially, I mean, once we're over that age of 65 with Medicare, we do our annual physicals, we do our annual vision screenings. Hearing screenings need to be a component in that as well.
Well, I want to give you guys a special thanks for, again, sharing this information and to our attendees. This information is going to be recorded and on our website. Is there anything else that you guys would like to add before we close out today?
If anybody has any questions, concerns, you can always reach out to us. We'd be happy if you had any additional questions or concerns to answer those to the best of our ability. Technology, things are always changing information. So staying up to date. This is probably not be relevant in a year. It might be more information on it. So keeping that into context.
Absolutely, yes. That's exactly what I was going to say. If there's anything that we touched on, didn't get to dive into that piqued your interest, please feel free to reach out. That's what we're here for and enjoy doing. And I just want to say thank you to you, Melanie, and your team for organizing this. And thank you all for taking the time out of your day to come and listen to what we have to say. We really appreciate it and we enjoyed it.
Well, thank you so much. And again, this is part of a series that we're planning to have We're also planning to explore things on optical health, dental health, and other items, and talk more about how these things play into overall health and well-being, and how important it is to be looking at these things on an annual basis to be sure that our overall health is as great as it can be. So thanks again, everyone. We appreciate it. Things will be on our website. Reach out to us with questions. Thank you.
Thank you, everybody.